Good morning, good afternoon, or good evening, wherever you're joining us from. Thank you for being here. I'm delighted to welcome you all to this exciting new chapter of Fast Track the Cure. If this is my first time meeting you, I'm Derek Ambrosino. I work with TB Alliance and help to support the awesome partners. We've had a chance in the past and present to work in the past and present on the Fast Track the Cure initiative. As many of you know, Fast Track the Cure was launched with a bold mission to help ensure shorter, simpler, and more effective treatments for drug-resistant TB reach every person around the world who needs them. And to do that, we bring community-based partners around the world together. We work in support of the WHO's call to action to accelerate access to shorter DRTB cures for all, and we collaborate closely with Stop TB, especially with the Challenge Facility for Civil Society movement. Today, we're proud to introduce the second chapter of Fast Track the Cure. The first phase of Fast Track the Cure focused on raising awareness about new, safer treatments through impactful digital campaigns and the establishment of the 6 months max hashtag, as well as extensive community engagement across several countries. Building on this momentum, phase two emphasizes enhancing access to these treatments, and today we'll outline our plans and actions to help achieve that goal. You'll meet a wonderful collection of new partners who are deeply committed to improving global TB care and empowering communities to do it. You'll hear about the activities they have planned over the following years and the challenges that they seek to overcome. The bulk of our time today will be spent hearing from our implementing partners, and we want you to participate in the discussion as well. There'll be a moderated Q&A with these partners in the second half of the event, and we encourage you to contribute questions for discussion. You could ask a question at any time. You don't need to wait until the start of the Q&A. However, we ask that your questions be submitted through the Ask a Question, the Q&A portal in the Zoom webinar interface, as that's the only way that the moderators and hosts will actually be able to see your questions. Also, don't be shy about letting your friends and colleagues know that you're joining us here today. Feel encouraged to post about the webinar on social media, and if you do, use the hashtag 6monthsmax. Louis, our social media guru, will drop into the chat a list of each of the new partners' social media handles across the different platforms if you want to add them on any of your posts, etc. So without further ado, let's get the show on the road. I'd first like to introduce Sandeep Juneja, Senior Vice President of Market Access at TB Alliance. Sandeep has helped craft and lead the global access plan for Protomanid and the BPAL and BPAL regimens. This is the fastest rollout of a new TB drug in the modern era. And when putting this blueprint together, he knew that empowering and engaging communities would be critical to achieving this vision. So please, let's welcome Sandeep.
Thank you, Derek. Okay, should be working now. So, so as I said, I'm Sandeep Juneja. I lead the access function at TB Alliance. I'm thrilled that we are unveiling Fast Track the Cure 2.0, which not too long ago was a pilot, was an experiment launched just a couple of years ago. And that initiative, along with several other initiatives by TB Alliance and many other partners, have led to, as Derek said, perhaps the fastest ever rollout of a new TB treatment in recent times. And not only was introduction of Pretomanid fast, but it was also perhaps the most comprehensive ever executed by a single organization in recent time, of course, along with many other partners in the global health space. So at the outset, right in the market research stage, when you're introducing anything new in the world, whether it's a for-profit or non-profit sector, you do market research to see what the field wants, how you should go about doing things. And this was even before Pretomanid was approved. We consulted extensively with a wide range of stakeholders, including, very importantly, the communities, a constituency that many of you in this webinar today represent. And a clear feedback we received was to prioritize and invest in access, and which really set us on the path that we took, and we did listen and we did invest in projects, time, effort, resources to stimulate the use of the treatment. Several access projects launched over the last 5 years since the first regulatory approval of predominant. And the first one was LiftTB that helped generate local evidence for initial implementation. Then there was SlashTB to support decision making for implementation. So these were really projects that help set the stage, but and generate field evidence. But right after that, when we got going into implementation stage, we began working with communities once again after the initial information gathering and guidance. And the first effort of the Fast Track the Cure, the way it is known today, was in the Philippines, which led to Fast Track the Cure, the way you see it today. And it was how to involve communities into informing implementation. Uh, and several other projects followed from that, which I won't get into given the limited time we have today. But this is what I just wanted to highlight to the participants of this webinar today, how crucial has been community engagement right from the stage of thinking about how to bring BPAL, BPAL-M, and predominate to the field, and then right at the beginning of implementation and scale up. The result of this comprehensive effort with multiple initiatives that I showed on the previous slide has been perhaps what I was saying earlier, the fastest ever uptake of a new TB treatment. It's been up to 10 times faster than what we had seen in the past. And it allowed us to achieve scale for the new drug predominant much faster than in the past. And with higher volumes of manufacturing, with scale, comes the possibility of reducing costs. The cost follows very rapidly when the volumes go up. And this is what happened. The cost and hence the price of predominant began coming down. And that aided with a similar dynamic that was playing out for bedaquiline, made BPAL, BPAL-M regimens cheaper. And you can see these green downward arrows show price reduction. Predominant was launched first in late 2019, but in December 2022, there was a 34% reduction on the price of predominant. And then afterward, there were a couple of small reductions, and recently there was a 25% reduction further, with a third manufacturer coming into the market. So while predominant started pretty low at $364 for a treatment, it's down to $169 already. It's the fastest price erosion or reduction we have seen in recent times. But what does that mean to all of us, really, who care about ending TB, about making really innovations, making an impact on health? So we tried to estimate what is the impact of PPAL today and what's going to be. And again, this itself can be a very long topic, but I'll just speak about what we are doing today, how it will impact us over the coming few years. So over the next 10 years, we estimate that BPAL, BPAL-M implementation will result in more than 300,000 incremental or additional treatment successes. It should save close to 180,000 lives, avert nearly 5 million DALIs, which means disability adjusted life years. That's the years that one lives in poor health or premature death, imperfect health. You're saving 5 million of those life years. We found that the simplification of treatment, making it all oral, reducing the time frame, contributes as much as half of the success rate. So half of it is because of the drugs work better, they are more patent, they cure better. there's certainty of success of treatment, but 50% is because it's simpler. That means people don't have to keep going back to the clinic for a year or for 18 months. They just go for a few months of follow-up and they're done. Uh, that makes it a lot more successful, which was really very heartening to see. And that is really informing future direction in the field, that every month you reduce on treatment is going to help. So today you are at 6 months. If you come up with 3 months or 4 months of treatment, that's going to help. That'll add impact. If you come down to a month, that'll be huge. And end of the day, what does it mean to the donors who are really driving our field? Is it'll result in $1.2 billion in savings. That means there's more money available to invest in other health uh, activities, including in the field of TB, in field of DSTB. It could mean more support to the communities and to the patients if you can save money on drugs and on follow-up costs. So that's what I wanted to share mainly with you. I also wanted to share with you that um, uh, developing new treatments is only part of the solution. Ensuring that they need people is really um, uh, what's critical. And for that reason, TB Alliance, along with its partners, is working deeply in the field where the need is. And over the last 3 or 4 years, starting from zero, we have expanded our efforts, working on the ground with local partners, with communities in a range of countries. And this slide is just a representation of where we have direct projects. Several of them, we have community-oriented projects, and we look at continue to grow that. So with that, I'll stop and hand over to my colleague, Akshaya Patil, who's running Fast Track the Cure, to speak about, Fast Track the Cure 2.0 and the vision for the future. Over to you, Akshaya.
Good morning, good afternoon, and good evening, everyone. I hope I am visible. Okay, I think I am now. Thank you so much for joining us today. It's a real pleasure to be here with all of you. Over the next few minutes, I'd like to take you briefly through the FTTC journey so far and share a glimpse of what lies ahead as we move into its next phase. As many of you may be aware, FTTC is a community-focused initiative designed to raise awareness, expand reach, and accelerate the rollout and access to new DRTB treatments. But at its heart, FTTC is about putting TB-affected communities in the driver's seat, not just as recipients of care, but as catalysts of change. Our core pillars include educating communities, raising awareness about DRTB and its treatment, facilitating meaningful engagement in the TB response, and building the capacity of people and networks who can help drive change. While FTTC 1.0 focused on laying that foundation by creating awareness of new DRTB treatments, sharing survivor stories, and engaging communities across countries, FTTC 2.0 will build on that momentum, supporting communities to lead the change on demand generation, monitor access, and really work alongside the health systems to ensure treatment reaches the people who need it the most. Next slide. So we started the FTTC journey in 4 high TB burden countries: India, Indonesia, Vietnam, and Philippines, through catalytic grants to 4 incredible community partners: GCTA, YKI, TB People Philippines, and FCDI. Each of these partners led a highly engaging traditional advocacy and digital engagement coupled with community mobilization to promote rapid and equitable access to the new 6-month BPAL regimen. Together, they co-created the 6-month max digital campaign as well. Our partners closely collaborated with each other and facilitated cross-country learning by periodically sharing and exchanging ideas, insights, and materials. I would also like to acknowledge and thank Stop TB Partnership for being a strong partner and ally for the FTTC campaign from the very beginning. FTTC also complements the model and approaches of challenge facilities, and where possible, we also look to leverage the partnerships from its network grantees. Next slide. So these are just a few highlights that capture the reach and impact of our work under our first chapter. By no means this is an exhaustive list. But just briefly, we reach over 43 million people digitally across 34 countries. Our partners developed a rich library of survivor, influencer, and advocate videos, along with educational materials that were tailored to local context and country needs. We also helped sign a global petition calling for universal access to the 6-month DRTB treatment by the end of 2024. This petition was signed by 15,000 plus individuals from across 150 countries. As I said, this is only a very brief snapshot of the amazing work that our FTTC 1.0 partners did, and probably a fraction of that work under the entire campaign. So I would urge all of you to visit our social media or our website or our partners' websites and social media handles to deep dive and learn more about the amazing work that was done by them. Next slide. Yeah, this is just a visual spectrum of the amazing work that happened. All these resources and content are available on the FTTC website. And as I said earlier, I would really urge you to have a look at it and amplify and use them as much as possible in your local context. Next slide. Coming to FTTC 2.0, our journey now moves also from awareness to action by driving community-led monitoring and demand for TB care, whilst putting TB-affected communities at the center of it all. We are building on our learnings from FTTC 1.0, recognizing the importance of community leadership, listening to lived experiences, all this while staying agile in our approach. With those learnings in hand, I'm really happy to share with you our new FTTC partners. And of course, we will continue to work with our FTTC 1.0 partners. But for our next chapter, we are proud to have on board Aspat from Peru, Dopasi Foundation from Pakistan, Nari, Maitree, Bangladesh, TB Network, Nigeria, and Reach from India to lead the next phase. The core strategies for FTTC will be centered around enabling community-led monitoring to identify access gap, take that feedback back to the health systems and work closely with them to bridge those gaps, strengthen capacity for long-term sustainability, drive demand creation, foster cross-country learning, and of course, strengthen peer networks for strengthening the DRTB cascade of care. Next slide. With that, I'd like to close my little presentation, but I would like to take this opportunity to thank each and every one of you, our partners, 1.0, 2.0, Stop TB, TB Alliance, the community at large, and all of you for continuing to support this campaign. Next slide. With that, I will open this up for the next panel, something for which we are all here for. James Maller from Stop TB Partnership, who we all know would be moderating this panel. It's my pleasure to have on the panel representatives from our partner organizations, Dr. Malaysia, who's the Executive Director, Aspat, Dr. Kinzo Leman, who's the CEO of the Dopasi Foundation, Dr. Khaled, Director Program, Nari Maitree, Anupama Srinivasan, Deputy Director, Reach, and Teresa Jatta, Program Manager, TB Network. Thank you, everyone. Over to you, James.
Thanks so much, Akshaya. And on behalf of Stop TB Partnership, just wanted to really extend our appreciation to the TB Alliance and the Fast Track the Cure initiative for inviting us to continue to partner and grow this wonderful initiative. It's been really exciting to see this journey and this initiative take shape over the last period of time. And I recall at the most recent union conference We had a wonderful session bringing together the 1.0 Fast Track the Cure partners, who are all, I guess, based in the Asia Pacific region. But it was, particularly timely for that to be hosted in Indonesia and to hear of those experiences. And no doubt, as we progress over the coming months and year, this second iteration, which I guess continues to have a couple of partners from Asia, but also extends into the Americas and Africa, will also give us some new lessons, some new ideas, and hopefully continue the wonderful successes that Sandeep spoke to in his opening remarks. One of the things that I think I just wanted to touch on before turning to Malesio, is that from the side of Stop TB Partnership and the Challenge Facility for Civil Society in particular, one of the things that we have been told and we've been instructed by our communities delegations and our NGO delegations is the importance of investing in communities as part of the TB response, as a general starting principle. Second, that the Challenge Facility for Civil Society, in terms of as a package, which is small grants, which is technical assistance, which is sort of global and country level coordination, is something that can bring about effective change. And third is that there's a few different pillars of work which are critically important but are complementary. And I mention this because this Fast Track the Cure also really builds upon some of these. The first being really identifying and overcoming barriers to access so that anyone, anywhere can access the TB tools that they need. The second is on community-led monitoring and really equipping communities to be able to engage, to build capacity and to participate. But the third, and which very much goes to the heart of this, is demand creation. And it's that need or that right to really demand access to those TB services you need. And this is something which goes, I guess, to the TB response. It's something where we need to shift the culture so that we do demand access to the best quality drugs, the best quality diagnostics, the best quality prevention. And the Fast Track the Cure has been a really wonderful example whereby we can invest in communities to play this role and bring about meaningful change. We saw that in the first iteration, and now, I'd like to hand over to the first of our 5 speakers, Malesio from Aspat in Peru, to tell us a little bit about their plans going forward to implement Fast Track the Cure in Peru. So over to you, Malesio.
Hello, good morning, everyone. Thank you, James. Thank you very much. And this opportunity, I will briefly present our project first. Let me introduce you to Aspat Peru. Next slide, please. Okay. Aspat Peru is an innovative non-profit organization fighting for a future without tuberculosis and alleviating the suffering and saving the lives of people affected by TB in Peru. Our vision is eradicate tuberculosis in Peru and discrimination and stigma against people who have suffering from this disease. Our mission is we work to contribute to promoting waste actions and tuberculosis prevention and control. Our project is accelerating the implementation of BPL-M short-term treatment for drug-resistant TB in Peru. Our project is located in Lima, in Callao, because Lima and Callao, the station of drug. Okay, our activities capacity building on the short-term regimen people. Right now,
Sorry to
presentation.
interrupt. Sorry to interrupt, Melissio, but can you speak up just a little bit more? It's a little bit difficult to hear. If you can just speak a bit more loudly. Thank you.
Okay, thank you. Okay, the first activity is capacity building conventional people affected and technical work. The second is raise awareness among civil society organizations community workers about
Sorry, Melissio. Melissio, I'm sorry to jump in again, but can I suggest, can you maybe turn off your video? Because I think maybe it's the internet connection might be a bit slight. I apologize for interrupting. It's just we want to make sure we can hear all of your points. Please, you need to unmute, Melissio.
yeah, okay. Hello, can you hear me?
Yes, please go ahead.
Okay. Okay, thank you. Okay, the next activity is screening capacity and skill through training and education workshops for TV survivors and community leaders to provide information on people and TV drug resistance and interactive psychosocial support circle session implemented by trained TV survivors and linking people affected by TV to the new BPAL regimens. The last one is a collection of TV histories from people affected by TV who are receiving the new BPAL treatments regimen. The expect results is increase awareness of BPAL M treatment regimens among people affected by TV, health workers and key stakeholders throughout Aspat Peru, community schools, reduce access barriers to TV service by raising awareness about new and effective drug-resistant TV treatments. And BPAL-M through community-led monitoring using the One Impact Peru tools. The next is consolidate and disseminate knowledge about the experience and lesson learned from the development of BPAL-M in Peru for cross-learning and exchange within Peru and among countries with high incidence of drug-resistant TB. Next, please. Okay, thank you. I think the project is implemented with the participation of TB survivors, and this is key to eliminating the disease. They represent the voice of the voiceless, and they know the terrain, and they help reduce stigma, promote early diagnosis, support other affected peoples, improve treatments, adherence, and contribute their experience to formulation of more human, effective, and person-centered health policies. Thank you so much.
Thank you so much, Melesio, and apologies that we had some interruptions because of the volume and the clarity, but it was very clear at the end, and we appreciate your message. But I note as well now, just to immediately move to our friends at Dopasi. So we had our challenge facility partner from Peru, and now the challenge facility partner from Pakistan. And so without further ado, I'd like to invite Kins to share some remarks.
Hi, everyone. I think I'm audible. So thank you so very much, James. And thank you to TB Alliance for bringing us on board. And Stop TB Partnership has trained us well to effectively engage communities. So thanks to Stop TB on that. And we're truly excited to be working with the TB Alliance. Just to introduce Dopasi, can you go to the next slide, please? So the Dopasi Foundation is a community-driven organization focused on strengthening demand side of health and development by empowering communities, amplifying the voices, and fostering grassroots engagement. We implement innovative interventions to reach the most marginalized populations and those missing care. And at the same time, we work with policy level to kind of informed decision making and advocacy for systematic change, because you can't only engage communities, empower them, and sort of train them to raise for themselves. You really need a policy backing there. So we have established parliamentary caucus. We engage in global health advocacy through multiple platforms to really ensure that community priorities are reflected in the national and global decision making. Can you enter a bit of the activities, please? Can you press next? Yeah, just keep pressing next till all the activities are there. They're going to be 6 tabs. So at the Dopasi, we believe that defeating TB, especially drug resistance, requires more than just medicines. It requires trust, it requires inclusion, it requires community engagement, as Akshya and Sandeep mentioned. We truly commend the super awesome turnout for ensuring the access to people regimen, and the TB Alliance has truly done an awesome job there. But for us, engaging the community now from the demand side of things is gonna really sort of take the things to the next level. Under the Fast Track to Cure 2.0, our approach is focusing on 3 key main pillars, just to sort of give a context of it. First, we're amplifying awareness and demand for new DRTB regimens that people often aren't informed of, like the community in general. A person can think that, oh, my grandfather received a treatment that was 24 months, that was all injectables. So at the community level, for people to actually know, okay, now a treatment with less side effects, which is more effective, is available out there, and they are actually going to demand for it, is what we are targeting at. And then to kind of one way or the other mitigate stigma. And we're working to change that by building community confidence through targeted education, peer-led outreach, and real-time dialogue. In terms of the key second pillar is putting communities at the center of accountability. Through digital platforms and community-led monitoring, we are enabling affected communities to voice their experience and shape the services they receive. This will shift the power dynamics. People are no longer just recipient of care, but are active participants on improving it, just like Akshya mentioned in the start. And third, we're focused on building system that lasts, whether it's nurturing peer support networks, strengthening ties with national TB programs, or embedding community into policy. We're ensuring that the progress doesn't end with the project. It becomes part of the system. Ultimately, Fast Track to Cure 2.0 is about closing the gap between the people and the health system so that no one is left behind and every voice is heard. Thank you very much.
Thank you so much,
I
Kins.
already covered all the outcomes.
Yeah, I think that was very, very concise, very to the point, Kins. Much appreciated. I think something that people might want to understand a little bit more on is the the parts around engaging the parliamentary caucus that you spoke to. So that might be something that, you know, I leave it to the listeners to see if this is something to hear more. But I thought that was an interesting component, noting that, you know, what's clear, I guess, even from the two presentations so far, is the different elements and the different approaches that are really fundamental to demand creation, and the fact that you can approach this in very different ways in different contexts. So thank you so much, Kins, and thank you to Dopasi. And now to move to Bangladesh, and we have Khaled from Nari Maitree. So I would love to, you know, to hear a little bit about the approach that you are planning to take as part of Fast Track the Cure 2.0 in Bangladesh. So I guess we move to the
thank you, James. Okay. Thank you, James, and thank you, everyone, for participating here. So yes, we would first to say about some Nari Maitree first. Then we will go to what we'll do under the Fast Track to Care under the 2 here. So Nari Maitree is a women-led organization in Bangladesh established in 1983, and as we help, our mission is to empower and establish the disadvantaged population, particularly the key vulnerable population, including women, children, adolescent, and marginalized urban communities. So in track, we have a great partnership with the Stop TB Partnership Global Fund. We are working in Bangladesh since 30 years, especially particularly on the TB. So we have a great experience to work with the like Global Fund, and also we have implemented project with the Stop TB Partnership, and now we are very good proud partner to the TB Alliance to establish the people in Bangladesh. And now, if we come to the plan of our what we want to do about our under FTA of Fast Track the Cure, specifically particularly in Bangladesh. So we particularly select 2 areas of the Bangladesh like Dhaka and Narayanganj, which is the most urban centers facing significant GRTB burden. Specifically, these have some high density population and also some the great slum population in here. So under this intervention of this Fast Track the Cure, we have some intervention package that we specifically designed directly for address the critical barriers that for the TRTB detection, treatment, and also the patient instant care. So these are the just interventions that we will doing the capacity building. Under the capacity building, we will train 30 people ambassador, including the community health workers, TB survivors, and DOT providers. They will act as ambassador for this people system for us. And we will also under the knowledge generation and behavior change, we will conduct a baseline and inline knowledge, attitude, and practice assessment. By that, we can get the information from our specifically from the baseline, and also we will develop a disseminate and ICBCC materials, which will think that this better materials will tailor specifically to address the stigma and also the misinformation and low treatment seeking behavior. So as there are some still some facing the problem of DITB patients in Bangladesh, and we will then, that's why we will establish some peer support groups and digital support movement, digital feedback system. Specifically, we can use the One Impact apps that we have already tried to some pilot basis implement in Bangladesh. So that's One Impact apps can help us to mapping the services and report the success barriers. So we'll talk with more about how we can involve the One Impact app in this feature also. And specifically, this is very important to work with the NTP. We have already worked with the NTP persons, specifically National Tuberculosis Program, that they will going to the updated the 4th edition of the national guideline and operational manual. So we will try to include to the people system into the new guideline. So I hope it could be strengthening and referral linkage and also the health system coordination. Next slide, please. Okay, thank you. Specifically, that's why I think why this work matters, particularly for the TB community in Bangladesh. As you know, some of you, that the Bangladesh is one of the 30 high TB burden countries, and specifically the 7th rank for the TB patients in the all over the world. In 2019, 3,300 estimated MDA TB patients then found, and only 42.4% was diagnosed. So that's 1,200 started the second line treatment. So it takes a long time, specifically for the patients who are the MDA TB patients, to make them the cure. But we will try to talk with the NTP and try to update the PMDT guidelines that will promote the community-based care and early diagnostics. So, but still there are some barriers still happening, like gaps in screening the children and high-risk groups, like key vulnerable populations. And also there are some very limited training in here, like for the people regiment, specifically for the DOT providers. And all around the fear, specifically the slum area and also in some high social area, the stigma and fear around when the patient's attacked by the DRTB, they think that this a very there is not any curement for here. But this newer treatment, like people could be to help them to reduce their fear and stigma. And also there are some low treatment seeking behavior, and specifically the urban slum population. And also the referral linkage we need to work in here. There is some weak referral linkage and also limited participation of the community. So as the community-led monitoring, we are very much engagedly working with the STP partnership. So we will try use our experience for increase the participation of the community voice, how we can plan it. So though this is initially a 1-month program, but the outcome, as this is initially that was the awareness, but we are going to access the program. So as the outcome, we think that enhance the community awareness and also the early case detection, that could be increase the local entrepreneurship and also behavior change. That is very important. So behavior change communication. So if you introduce the BCC and IC materials, that can be helped to reduce the stigma, dispel misinformation, and empower patients and families to seek earlier care. And also, when we make some peer groups, that peer support groups and the survivor networks will provide counseling, emotional support, and shared experience to improve the enhance to the deeper treatment. And when we will working with the community, so our community feedback mechanism like digital tools, One Impact, that will enable our real-time monitoring of service barriers, patient experience, and referral gaps. We can discuss in there and get the feedback from them, how we can assist our community, and also make our healthcare system stronger by making this thing, including in the national policies. So I think Narimuthi's engagement, specifically, particularly in the Fast Track the Cure, is designated to convert community awareness into the tangible access of the DRTB services. So we hope Narimuthi can contribute particularly in Bangladesh significantly to advance Bangladeshi national NTP goal, and that will ensuring that the most vulnerable population are not left behind. So thank you. That's from our end. If there is any question, you can ask. Thank you.
Thank you so much, Khaled. And it was really, really good to hear, I guess, a little bit from the perspective of Bangladesh and how Maitree sort of is planning to approach this. And a couple of things that were really striking for me. And one was the fact that through Challenge Facility, there's been a range of different pieces of work that have been advanced and developed at country level, including, say, community-led monitoring, stigma reduction, key and vulnerable populations work, and also this demand creation. And what we can see here is that the intersectionality across so many of them. So I think that that's something that's quite interesting here. Second, you made some really interesting points about close engagement with the national TB program. And I know that this was touched on by others as well, but I guess this is such a critical component of affecting change at country level. And the third thing, you, in addition to Malesio and Kins, all spoke to TB community-led monitoring and One Impact. I know that now there's over 300,000 users of One Impact globally. So it's actually a really powerful platform which has a lot of potential to impact change. And so this is something which I think is, has the potential to continue to really shape demand creation efforts going forward. But thank you again, Khaled, for your reflections. I think it sounds like it will be really interesting work. And now to move, I guess, to our friends in India, to Reach. And so, Anu, please, over to you. I guess that it's interesting with India. Something that's maybe unique here is certainly that India is featured in 1.0 and again in 2.0. So a really interesting opportunity to continue the efforts in the Indian context. Over to you, Anu. Thank you.
Thank you so much, James. Just confirming that you can hear me. And on behalf of Reach from India, we're really delighted to be part of this launch webinar and work together with fantastic partners and build on the previous work that FTTC 1.0 partners have done as well to really strengthen community-led response to drug-resistant TB globally. I think many of you, for those of you who don't know about our work, if you could just click on the slide, please, till all four. Yeah, right through. Thank you. So Reach is a 26-year-old organization based in India. We've been working with the private healthcare sector, with the TB program, of course, providing direct care and support, but also working very closely with TB-affected communities, particularly TB survivors. And in India, for this particular work with TB Alliance, our starting point is a large cadre of empowered, committed TB champions that Reach has been working with since 2016 and is now a movement across the country today. Stop TB, of course, has played a major role in making this possible, and I'm happy to share a little bit more about this later if we have time. Through this particular project, we have an opportunity to add a layer of, to the work that champions are already doing, add a very specific focus on DRTB. I think in general, there is this idea that if TB is thought of as biomedical and complex, DRTB is all the more. And I think the work that we're going to be doing really presents an opportunity to change this notion, to show that communities can be thought leaders when it comes to drug resistance as well. Next slide, please. So what we're planning to do over the next 10, 11 months is we're working in 5 DRTB high burden states in the country. And we really have a 2-stage approach. The first is building community capacity on drug-resistant TB, understanding the new regimens. This is a great time to be doing this. The shorter regimens, BPAL, BPALM, have been formally adopted. They're being rolled out. Health system capacity is being built. And in tandem, we're able to build community capacity. So we're training 100 TB champions from these 5 states to understand drug resistance, understand the treatment regimens, why these matter so much to people with DRTB. Some of our TB champions, of course, are DRTB survivors themselves. And once they're trained, that's when the second stage comes in, and they'll be doing that 2 work pathways in a sense. So one is in the community itself, building community understanding of what drug resistance is conceptually, what regimens are available for DRTB, what diagnostic cascades are there, and what communities can and must have access to. So just building that knowledge in communities, in their local communities. And second, at the sort of facility level, where the starting point is someone who's already been diagnosed with DRTB and is going to be treated through one of the shorter regimens, BPAL, BPALM, based on the assessment. So what is that person's experience going to be like? How can the TB champion play that peer support role? Of course, while keeping, looking after themselves and ensuring that they don't, making sure self-care is a major part as well. And finally, through this process, we're really hoping to document all of this, document the experiences of TB champions and document the experiences of people with DRTB whom they support, because I think this is a great opportunity for all of us to learn when BPAL is being rolled out, and not both in country and globally. Finally, I just want to say that, you see all these numbers on the slide, 100 TB champions will reach out to 43,000 plus people. But I think fundamentally, what's really important for us, and Sandeep alluded to this earlier when he spoke, is that fundamentally, we know that TB champions can help people get diagnosed sooner. We know that they can advocate for for access to upfront testing, for NAT. We know that they can provide that really invaluable emotional support to help someone with DRTB complete treatment. This is at an individual level. At a program and system level, what we're really hoping is their efforts will not just improve knowledge of DRTB, but also help reduce delays in diagnosis, reduce LTFU, improve treatment outcomes, and end of the day, reduce mortality. I think that's really our mutual goalpost, and it's TB communities who are best positioned to lead these efforts. I just want to end by saying a big thank you to TB Alliance for investing in communities, particularly at a time when the landscape of global health funding is dramatically changing, and we're all worried that engagement of communities will once again not be a priority. So this is a great opportunity for us to show how important this is, and we're very much looking forward to the next 1 year. Thank you so much. Back to you, James.
Thanks so much, Anu. Really appreciated the reflections there. And I think that there's some wonderful work that's sort of played out in India with the movement around TB champions. It certainly provides this grassroots movement for change. And it demonstrates, I think, a lot about the value of investing in communities as part of this change. So I think that it's a very exciting, process that we can see play out in India for this. I note as well that, the next iteration of Challenge Facility for Civil Society will hopefully be, announced in the coming weeks. And it's certainly one which, with support from L'Initiative France and UNITAID, will have an enhanced focus on DRTB and demand creation. Sorry, that was my timer. You finished early. And so I think just so that people are aware, I guess, that this initiative from TB Alliance and Fast Track the Cure, it certainly fits into sort of a broader effort that's going to be undertaken, in the global TB response, which is very exciting as well. So now to move to Nigeria. Great to have one of the countries in Africa which has such big challenges with DRTB, but also some really wonderful examples of innovations, of political leadership, of community-led demand. And so I think I wanted to now hand over to Teresa from the TB Network Nigeria. So for us to hear the fifth and final presentation from our 5 FTCC 2.0 implementers. Over to you, Teresa.
Hello, everyone. Thank you for taking your time to be on this call. I'll be speaking on behalf of TB Network. My name is Teresa Larabajato. So TB Network, that's the short abbreviation for the organization, but we are a civil society organization for the eradication of tuberculosis in Nigeria, and we are a non-profit. We began operation in 2009. Interestingly, we have over 600 membership across Nigeria, including the FCT, that's the Federal Capital Territory of Nigeria. Our vision is to have a TB-free Nigeria. Our mission is to coordinate the civil society organizations in advocating for increased access to high quality and comprehensive tuberculosis services in Nigeria. On this project, we're going to be working in Kano and Katsina State. The goal of this project is to strengthen community engagement and awareness of novel DRTB treatment regimen, which is a BPAM, by increasing demand for services, establishing a community-led monitoring and evaluation system, and fostering cross-learning through an evidence-based documentation with the overall aim of improving treatment uptake and health outcomes. Now, this is very critical to the work that we do at TB Network. We are the community, representing the community voices, and we represent everyone in our sphere, in our constituency, which is people living with TB or people affected by TB in each of the community where we intervene. And so our key activities for this intervention is to adapt the DRTB training manual and conduct community DRTB and BPAM training of trainers, which will be cascaded down to the community in these 2 states. We also are going to be conducting a lot of awareness and sensitization campaign. We also distribute IC materials on BPAM treatment. We'll be collaborating with local media to air jingles, because we believe that when people are aware, then they can be able to be intentional about accessing treatment in the facilities. And so we'll be doing a lot of jingles. We'll be doing a lot of radio shows to create a lot of awareness, sensitization, and people will now know where to go to. Then we'll also be collecting data using the One Impact tool. We've heard a lot about One Impact tool. And so this is it's the key, it's a game changer for us. And we are emphasizing on the AAAQ, and that's in no particular order, that's the access, availability, affordability, and quality that becomes a barrier to people accessing care. So we're going to be using the One Impact to tease out this information. And the information there will help us to know how to program better and what to do to bridge the gaps that we may have identified. And then we'll be documenting the experiences of CBOs, healthcare providers, and DRTB patients. Now, this is very critical. Without this documentation, we'll not be able to know what is going on and what is working and what is not working. So this is very critical to then document these experiences. We'll also produce a short video about DRTB patients. Now, again, this is very important because this gives us a human angle to DRTB patients' experiences. It is critical to know what they think, how they feel, and how they are able to cope through the challenge that they are facing. Now, also develop and disseminate project learnings, success stories, and then, of course, the closure report within this 12 months of the intervention. And we'll also be sending this report to TB Alliance and National Tuberculosis Program here in Nigeria, so that at the end of the day, we want to see how this can be scaled up. This can also be replicated in other states. Recall that we are going to be starting in just 2 states. So we want to see how we can be able to have this done across other states in Nigeria. Next slide, please. So some of the outcomes that we hope to see in this intervention is enhanced capacity of the TB networks national. Of course, we are this level, we're going to be trained, and then we're also going to be cascading to subnational level. We also want to see increased community knowledge and awareness of DRTB and BPALM treatment, and the services becomes readily available in our communities. We want to see improved public knowledge on DRTB, improved community participation in addressing the challenges of the AAAQ, BPALM treatment, and DRTB services, like I mentioned. We want to also see improved economic resilience of DRTB patients. We want to see increased literacy and adherence to BPALM and improved psychosocial well-being of DRTB patients. And this is very critical. We want to see evidence-based information to inform perception gaps and challenges of BPALM that will be identified and properly documented in the course of our work. Now, why is this important to the work that we do in the community? Number one, it strengthens community engagement in DRTB response. So this project is going to emphasize community engagement in the DRTB response by empowering TB survivors, leaders, media, and local groups with essential skills and tools. Secondly, promote the uptake of BPALM, a shorter regimen, safer DRTB treatment regimen. The BPALM regimen offers a shorter, safer, all-oral treatment for DRTB in Nigeria, with the potential to transform TB care and ensure that people adhere to treatment. So this project is going to promote uptake by raising community awareness, understanding, and demand, ensuring those in need can access and complete their treatment. And thirdly, we also want to build a community-led monitoring system for accountability. Now, we all know that community-led monitoring is a tool, is a model, right? It's a model that ensures sustainability. It's a model that ensures accountability and ownership. So through this model, we want to see that the system is empowered and individuals are also able to use the One Impact. And also we are going to be using the client exit interviews and participatory data collection to get individuals' feedback and suggestions possibly on what to do well. Thank you all very much for listening, and thank you to TB Alliance, and we look forward to a sweet, successful partnership going forward. Thank you. Over from me. Back to you, James.
Thank you so much, Teresa. It was another, fantastic presentation. I think it gives us all a snapshot into the wonderful work that you have planned in Nigeria. So that was the fifth and last of the 5 country level presentations. I think that there's a lot of really rich and interesting information that came out there, and I guess now there's an opportunity for there to be some questions. I know that there's already a few that have come through, so I just wanted to pose a couple here. So maybe I might ask 2 or 3, and then just to allow people some time to think on their responses. The first to colleagues at TB Alliance, just to ask one of the questions that came through was understanding the relationship between this initiative and I guess the partnerships with Global Fund and I guess by extension the Global Drug Facility as well. And so just to understand if you wanted to share a little bit about that, maybe this is one for you, Akshaya. And I think that there was one other one as well, Akshaya, that might be which might be good for you, which I just lost it. Sorry. Yeah, I guess it's to how do we ensure like the early diagnosis and getting people into care quickly around DRTB. That's a question that, maybe first can go to you, Akshaya, and or TB Alliance colleagues, and then, I would also ask other panelists as well. So over to you, Akshaya, to start.
Thank you. Thank you so much, James. I think what answers this question, and of course, I'll respond to the one on how the FTTC work can really work towards improving access to diagnostics as well. And I know the focus of our conversation has mostly been around DRTB treatments, but we also understand that without the accurate and timely diagnosis, the second part of the DRTB cascade really doesn't matter, right? And that's where, if you see the 4 pillars, the 5 pillars of FTTC that I initially spoke about, community-led monitoring, demand creation, capacity building, really work towards it. I think some of our partners' presentations also kind of alluded to it, where we're going to be working with the communities and these organizations to identify gaps in access and take them back to the NTPs. So these could be access gaps to, say, your NAT or your culture or your pre-treatment test, all the tests that have to be available, not just in the community, but also close to the patient and around the patient. So these are some areas which we've built into all the FTTC proposals, and of course creating demand around access to timely diagnosis by using community engagement and really the patient-centered approach. And of course, some of the projects are also doing capacity building around understanding what accurate diagnosis is and how it really flows during the care cascade. So these are some elements I would say the FTTC projects in detail have built, and I would probably pass it on to some of my colleagues if they want to talk about how they are going to be working very closely with some of the TB survivors, the champions, for improving access to diagnosis too. But having said that, it is mostly going to be to capacity building and really demand generation and doing that end-to-end community-led monitoring is how we foresee diagnostics being a key component of the FTTC work. Coming to the question on how the ongoing challenges with Global Fund and others have affected and how we want to step in, this is something that we are collectively thinking about, and we would be discussing these challenges with our partners and our partners at Stop TB as well, and would take some time to respond to in terms of how is it that FTTC can work towards mitigating some of the challenges that have risen through whatever has happened in the past few months. But I'll stop there. Maybe pass on the question, James, if anyone from the current set of partners want to respond to this.
Yeah, just maybe I can put 2 more with it, if that's all right, Akshaya. So for each of the panelists, maybe if you wanted to answer about the importance and also the challenges of early diagnosis, but also 2 others. One about the challenge of drug stockouts. And how if you see a connection between this initiative, or I guess between demand creation and ensuring access through continuous supply. And any of the, there's a question about the challenges for community engagement specifically for India, but I would extend that to all 5 of the country contexts. So if you can share a little bit, I guess, on challenges for early diagnosis, challenges for community engagement, challenges for drug stockouts, and maybe if you have an idea of how to respond to those. Now, I see Anu, you're like at the top of my screen. I wonder if I can go to you first, and then maybe I'll invite Teresa after that if you have a comment.
Sure, thanks, James, and thanks for the questions. I mean, there are definitely going to be challenges. There's no 2 ways around that. I think one specific challenge that we do anticipate is that sometimes we organize a training and we think by the end of that training, we're done with the training part and the capacity building. But I think one of the things, particularly for something as complex as DRTB, is that continued investment, time and energy in building capacity of communities, keeping that sort of channel open, not being prescriptive. And I think in the project setting, these are always things we grapple with. The second thing is, when I spoke about how this is a good time because BPAL is being rolled out. At the same time, that is also a challenge in itself because we all know when new regimens are introduced, the system also takes time to figure things out, right? It takes time for care to become less decentralized, for instance. So we may have a situation where in the first year or so, we have drugs available with the shorter regimens only in very few facilities because it will take time for that to happen. So how do TB champions sort of help accelerate some of this? How much of that can they take on themselves? And how do they work with the health system while both parties sort of figure the rollout process? And I think this is a challenge that we anticipate, but it's also an opportunity. It's good timing, like I said. So it is an opportunity from the get-go to have communities involved in this process. I'll stop there. Back to you, James.
No, that was wonderful, Anu. Thank you so much. Teresa, did you have any further points to add on any of those three topics? So the stockouts, the challenges of community engagement, and the importance of early diagnosis. You need to unmute, Teresa, yeah.
With regards to drug stockout, one of the things that have come to fore or to come to play in our country is the fact that as an organization working with the community, directly with the community and representing their voices, we have been able to work with other partners like the Global Fund, for instance, and they have been able to also make some procurement. So when we come to the point of drug stockout, like we have experienced in the time past, we have been able to leverage on other interventions, on other projects. And right now, we are implementing the MDR in 2 states, in Kano, Katsina, and Kaduna as well, 3 states. So, and also with the national program, we have been able to leverage on other interventions that have been going on and see what we can harness or how we can work together. So for instance, the KNCV, Nigerian, working in Nigeria in these communities, have been able to leverage so it's basically leveraging because of the fact that the drugs, we have the drug stockout issues and all of that. But right now, what I think that we can do, or how we can be able to ensure that we overcome this particular situation, is for us to be able to, like in this prioritization of the Global Fund, see how we can scale down on other interventions and focus on ensuring that we are implementing critical life-saving activities. So for instance, procuring medications, for instance, is critical to sustainability and ensuring that lives are saved. So reprioritizing and saving resources and also demand resource mobilization, I beg your pardon, would also help us to see how we can garner resources put together and see how we can be able to keep afloat in the midst of the global, in the midst of the drug stockout. So for me, it's reprioritization, saving fund, and ensuring that we keep procuring drugs to be able to help sustain the gains that we have over the years. That's what I would say for my end. Thank you.
Thank you so much, Teresa. And I guess, I'd love to hear as well a little bit from the context of the Americas on this. Malesio, any additional points that you wanted to add? And then I'd come back to Khalid and Kings.
Yes, James. I think the implementation of the BPAL regimens, shorter oral treatments for resistant tuberculosis in Peru represent important advance, but faces several challenges. One point is training of health personnel. The second, supply and access to medicines. Third, monitoring and adverse effects that require close clinical surveillance and advice event management capabilities. The next is timely diagnosis and susceptibility testing challenge. The need for rapid and access test to confirm resistant TB and guide the use of BPAL or BPAL-M. The next is adherence, the risk of dropout of interruption reducing treatments effectiveness. And the other challenge is national regulations and protocols. Maybe is important because we need put the policies and guidelines and regulatory approval for widespread use. Cost effectiveness and financial assignments maybe is important, and yeah, maybe is the participation of people affected by TB is very important in Peru. Is maybe is a very key challenge, but is that is a good participation for NTB. Thank you.
Thank you so much, Malesio. Khaled, anything extra you want to want to add? And then Kins, please jump in straight after Khaled.
Okay. So instead of that, specifically, especially the financing problem, we know the global complexity funding, specifically for USA and USA Trade. We are also not affected for this, for the Stop Partnership Project and the others. So, but we are now thinking how we can navigate this thing problem, the context specifically, particularly for the DRTB. Like we have going to the strategic alignment with the national priorities. Currently, we are aligned on intervention, closely working with the NTP and trying to attract both domestic and also the international funding alignment that are the priorities to the national TB priorities. And also there is some evidence-based advocacy, that we get some data from a previous experience, like from the KAP assessment, One Impact app community feedback from the CLM. We have some genetic data that we already have that could be our using to advocate for the sustainable investment for the future upcoming. And also we need, as this crisis moment, like where people are going for the where rather than a humanitarian. So we should work some of the cost-effective models also. Like we can promote some community-led interventions that are scalable and cost-efficient, and also utilizing the digital platform that we are using for the Fast Track the Cure, using the digital platform, and also that could be expand our reach with some limited resource. And also there are some partnerships, not only the government partnership and also some of the private partnerships, like engage multiple donors, private sector, corporate sector, and development partners to build the joint funding models that could ensure our program to sustainability. And also we make some sustainability planning that mainly we need to work with the government, like specifically for particular the NTP, that we will develop the long-term sustainability plans that incorporating the DRTB demand creation into the routine public health financing. So I think this could be the problem that we can navigate these complex issues, complex funding particular issues. So these points in our end. Thank you.
Thanks, Khaled and Kins.
Yeah, from Pakistan's perspective, I would say, just like others mentioned, we're engaging in high-level advocacy, engaging the members of the parliamentary caucus for domestic resource mobilization, going beyond the general partners to engage people beyond. And thanks to the support that we had from Stop TB Partnerships Advocacy Grant, we have even the First Lady on board, and we were able to get budget approved for 2 provinces actually from the domestic funding, and for Balochistan for the first time in like the last decade that their government PC1, the Planning Commission one, that is a government funding for the regular program, has been approved. Through Fast Track to Cure, particularly, we will be working on the access part of it, on the community empowerment part of it, using the community-led monitoring. We already have over 28,000 people on our platform, and we're working with TB Alliance to improve knowledge of the people to be able to mitigate the barriers with regard to access. So from the resource constraint perspective, we're relying on domestic resources, making best use of resources, integrated programming. And now with BPEL, we can actually say that DSTB sites can also start procuring, providing DRTB services. So a lot of things on the way. It's unprecedented times, but we are still excited for the partners like TB Alliance and Stop TB to be supporting us during these times, and we look forward to implementing with all the implementing partners.
Thank you so much, Kins. I think that that's, a lot of really good points there. Appreciate as well the particular references about leveraging the community-led monitoring work, also building off some of the work that you have done before, because I think that that's really key. We've had some comments, and some reflections about the current funding climate that we're in, or the current health, the challenges that global, regional, national, subnational health responses are facing simply because of the shifting context. And so it is really important to be smart, to leverage what has been done before, and to really look for opportunities to maximize what's being done. And I think that that's something that's really good about this Fast Track the Cure initiative. Of all of the proposals that all 5 country partners have put in, is, everyone is obviously aware of the context, but like that's one thing, but to go beyond that and actually take active steps to strategically make this investment go as far as possible is something that really should be applauded. So just really wanted to recognize all of the partners for that. So look, I do have another question that's sort of come up here, which I think is it's like, I would like to ask each of you, maybe just in 2 sentences. What would you tell somebody who is online and not located in a high TB burden country, who wants to ensure shortened DRTB treatments and, maybe diagnostics as well, can reach all who need them? What's your one piece of advice? What's your advocacy message? What is it that you really want to see change? So yeah, Kins, you're on my screen. I'll start with you, or we go in reverse order. So Kins, and then I go to Khaled. So
for me, the key message these days is the BPEL regimen has made it possible that you can treat DRTB in 6 months without the side effects. So we need to ensure, we need to engage private providers, we need to engage community providers, we need to engage our normal DSTB service delivery units to start providing service. Community engagement is the key for that to happen, which we are already paving the way for.
A long 2 sentences, but they were good 2 sentences, Kins. Thank you so much. Khaled.
Okay, thank you. So from my perspective, community engagement is the key. Like, we have working directly with the community. So I think community-led initiative is the most priority thing to take the people into our people effective. So though in our country that is not effective till now, so we can work with the community, like community level monitoring, CLM. This is the main approach for us to go to the community.
Thank you so much, Khaled. Melesio.
Yes, James, we need the voice and strength of those affected at all levels, in technical round tables, in political decisions, in information campaigns, in drug distribution and monitoring effective access, because tuberculosis is not just bacteria, it is also poverty, stigma, inequality, and silence. And that is why the end of TB will not only be a medical achievement, it will be a human and collective achievement.
Thank you, Melesio. And then Teresa?
So for TB Network, I would say that we are going to be, our key message is the community-led monitoring. And again, thankfully, we have shorter regimens, so there's no excuse. I mean, it's to advance the message, pass it, and let everybody know that this is it. And so the community-led monitoring for us is the way to go. Thank you.
Thank you so much, CLM. And Anu?
Thanks. So I think my elevator pitch yes, invest in what's life-saving, but life-saving isn't just drugs and diagnostics, although of course those are critical, but also the value of lived experience can save lives. And I think that's so investing in communities, investing in continued investment in TB research, for vaccines, for other new tools. I think these are really things that I'd say to someone who isn't worrying necessarily about TB in their own country. Thanks.
Thanks, Anu. And like, I might just close this one part of the panel and just maybe like, share based on what I've sort of heard from all of you. And, is that I guess my message and my takeaway is that we have a lot of exciting new tools available to us in the TB response, more than we've ever had before. But these tools are only as useful as people are able to access them. So we need to ensure that all people, all key and vulnerable populations, no matter where people live, no matter where people work, no matter the identities that people have, can get access to these services, to get access to these diagnostics, to get access to these drug regimens, to get access to preventions, to get access ultimately to new TB vaccines. We need to create a culture where it's the right of people affected by TB to get this access. And I think through these initiatives like Fast Track the Cure, we can start to see this sort of change. And we hope through Challenge Facility for Civil Society, we can continue to support this in many countries to really ensure that we can end TB by 2030. So I want to take the opportunity. Thank you, Anu, Teresa, Melesio, Kins, Khaled for your reflections, and best of luck in all of your work. From Stop TB, we'll be here to also support you along with your friends at TB Alliance. And now I want to hand back to friends at TB Alliance, to Akshaya, to close the session. Thanks so much.
Thank you so much, James, and all the speakers. I think this was extremely insightful and a lot of food for thought for all of us, just from the insights and experience that each of our speakers has shared. On behalf of the entire organizing team, a big thank you to each one of you who made time to attend. Your continued support to the campaign is invaluable. Please stay connected with us through our website, our social media handles, just to follow the next steps in our journey. Let's keep the momentum going and continue placing communities at the center of the TB response. Thank you once again, and have a wonderful rest of the day.
Thank you.
Bye.